So Jason had asked me to talk about metastatic triple-negative breast cancer and first line, how we would treat them. Just to kind of set a base, I know the slides didn't necessarily come through with the graphics and all that. So the way we would historically treat triple-negative breast cancers in the first line was primarily with chemotherapy, right? So, and then once we knew about immunotherapy, we would add IO if patients are PD-1 positive, but if they're PD-1 negative, then we would essentially use chemotherapy. And we would use drugs like Sacituzumab, these TROP2 ADCs, largely in the second line setting. And we know these ADCs are effective, or probably more effective than chemotherapy, but also less toxic. So it actually made sense to look at them in the first line setting. So that is essentially the question these studies are going to be looking at. So basically, we're looking at Saci or datopotamab in patients who are PD-1 negative, but with the addition of pembrolizumab if these patients were PD-1 positive. So we're going to be looking at 3 studies that were presented recently or published. So one is TROPION-Breast02, ASCENT-03, and ASCENT-04. And these are essentially looking at these combinations of answering questions about how ADCs work with or without immunotherapy in the first line setting. So the first study that we will look at is TROPION-Breast02. As you all know, TROPION is all basically the Dato-DXd based studies. So this was a first-line study looking at patients with metastatic triple-negative breast cancer who had not received any sort of therapy in the metastatic setting. And these were patients not considered to be candidates for IO, or they're PD-1 negative. And these patients were randomized to receiving Dato-DXd or investigators' treatment of choice chemotherapy. One thing to note is this study allowed only single-agent chemotherapy like taxane, erbuline, CAPE, or carboplatin. And the primary endpoint was dual for this study. So there was PFS analysis by BICR, and also OS was a secondary, dual primary endpoint. So this is, again, different compared to the Gilead studies. And then the secondary endpoints here was more looking at response rate, duration of response, and so forth. Patients who had progressed on investigators' choice of chemotherapy, they could actually receive ADCs or any sort of chemotherapy, but this was not specified on this study. And there was no defined crossover on this study per se compared to ASCENT-03 or 04. And one difference with this study is this study allowed patients who had progressed within 6 months of prior chemotherapy. Those patients were excluded in some of the other studies. And this kind of tells you about the baseline characteristics of these patients. It was fairly well distributed, and you can see the study also had patients who had progressed within 6 months of completing prior treatment. As you would expect with most triple-negative studies, almost 30% of them were de novo metastatic. And when you look at the chemotherapy distribution, you can imagine most patients actually ended up getting taxanes, as you would expect in the first-line setting. Few patients actually had erbuline, and few carbo and CAPE. And the choice of chemotherapy was pre-selected. So this was before randomization. So that's why you're actually seeing it in both arms. It doesn't mean like these patients got chemo in the Dato-DXd. And then the study showed that Dato-DXd significantly improved progression-free survival compared to treatment of physician choice chemotherapy. So it essentially doubled the progression-free survival from 5.6 to essentially 11 months. And Dato-DXd also showed a significant improvement in overall response rate, again, near doubling of what you would see with standard chemotherapy. And as I mentioned before, this study had dual primary endpoints. The second dual primary endpoint was overall survival, and it showed Dato-DXd improved OS and an absolute improvement of 5 months with a hazard ratio decrease about 21% compared to chemotherapy alone. And when you look at the toxicities, and we're all familiar with some of the Dato-DXd toxicities, as we know, like it has some ocular toxicities, primarily dry eyes, rarely keratitis, and that was observed, of course, observed in the Dato-DXd arm compared to physician choice chemotherapy. And the other issue we see with Dato-DXd is mucositis or stomatitis. So that was, again, more prevalent in the Dato-DXd arm compared to treatments physician choice. And we also know these deruxtecan-based ADCs also have significant amount of nausea, so that was also seen. What is favorable for Dato-DXd compared to SASI is that it's less marrow suppressive, so there was less of neutropenia and leukopenia in this group compared to treatment of physician's choice. And then, of course, we also saw alopecia and fatigue in Dato-DXd, but that was largely comparable to what we would see in the physician's choice chemotherapy. So they provided some updates at ASCO this year, and that was primarily looking at secondary efficacy endpoint. In addition to PFS and OS, they also looked at PFS2. I know Dr. MacArthur talked about, kind of the downsides of looking at PFS2, and they also looked at time to subsequent lines of therapy, first line and second line, and so forth. And you can see like Dato-DXd did better compared to chemotherapy in essentially all of the secondary endpoints that were looked at, including PFS2, TSST, and TFST. And of course, it's not surprising because OS itself had an advantage for Dato-DXd. And one thing that was not necessarily balanced is when you look at the treatment that these patients got after they had progressed, and you can see it was a little bit imbalanced, as you would expect. Patients who got investigator's choice of chemotherapy ended up getting more ADCs compared to the patients who had actually received Dato-DXd as part of clinical trial. We don't have Sacituzumab approved here, but it's approved in China. So, but majority of the patients in the US ended up getting Saci or TDXD. So that was TROPION-Breast02. So the ASCENT-03 is essentially looking at the same question, but Sacituzumab instead of datopotamab. And you can see like the population is largely similar. It was intended for patients who are not candidates for PD-L1 therapy or PD-L1 negative. And these patients were randomized to Sacituzumab versus physician's choice chemotherapy. One difference here is this study also allowed dual chemotherapy. So these patients could have either got taxane or carbogem. So TROPION-Breast was single-arm study. And then the primary endpoint was PFS analysis by BICR. OS was a secondary endpoint here. And what was important is this study allowed patients who got chemotherapy to get SASI as crossover upon progression. And when you look at the characteristics, it was largely similar as you would expect. The de novo group was 30%, and majority of these patients ended up being recurrent after 12 months. And we don't have anybody who recurred within 6 months as we had in TROPION-Breast02 because this study actually excluded those patients. And when you look at the chemotherapy these patients got, majority of them actually got taxane. And few also got platinum and CAPE as well. And that was pre-adjuvant or like prior to metastatic treatment. And when you look at the PFS, and it was very comparable to what you would see with Dato-DXd. Saci improved PFS to about 10 months compared to about 7 months with chemotherapy, with a hazard ratio about 0.62. The response rates were not that different. The absolute response rate with Saci was 48 compared to 46 in physician choice chemotherapy. But again, that is also because this study allowed doublet combination for the control arm, so which may have actually negated the absolute response rate difference. But what was important to note was the duration of response was still better in Sacituzumab compared to physician's choice of chemotherapy. At the time of primary analysis, OS was immature, but the PFS2 was longer, suggesting maybe over time the OS should show benefit towards Sacituzumab. But again, that was in the primary endpoint of this study, so that was more of a secondary endpoint. So hopefully we would, over time, we'll get more data on this OS information from this study. And again, looking at the common AEs associated with Sacituzumab versus chemo, again, we know Sacituzumab is more myelosuppressive, so a lot of these patients actually ended up having neutropenia. And these studies did not mandate necessarily to do prophylactic GCSF, which we now use as standard of care. And we saw a little bit more nausea as well as alopecia in this group, as well as diarrhea. But things like fatigue and other issues were more in the chemotherapy treated patients. And this is kind of to compare the differences between TROPION-Breast02 and ASCENT-02, and you can see in terms of distribution, largely similar. One difference is ASCENT-03 did not allow patients who had progressed within 6 months. And as I mentioned before, ASCENT-03 allowed patients to get doublet combination. Almost half of these patients ended up getting carboplatin and Gemzar combo, but TROPION was primarily single agent chemotherapy. We do have a longer follow-up for TROPION-Breast02, and the PFS is largely similar. As I mentioned, the overall response rate is a little bit better for Dato-DXd, and when you compare it to physician choice of chemo in ASCENT-02, it's not that different. And the other difference was in terms of what these patients ended up getting upon progression. So the fact that the study allowed patients to get SASI upon crossover at progression might make it harder to show an OS benefit, so that's possible. So now we looked at data for ADCs in patients who were PD-L1 negative. So the ASCENT-04 essentially was designed to look at the benefit of adding ADCs in patients who were PD-L1 positive. So essentially the same design. So these patients ended up getting SASI plus Pembro or chemo plus Pembro, and these patients should have been PD-L1 positive based on CPS 10 or more by 22C3 assay. And these patients should have progressed at least 6 months after neoadjuvant or adjuvant therapy. And again, these patients were allowed to cross over if the chemo patients had progressed over time, but the crossover is essentially single-arm Sacituzumab. And the PFS, similar to ASCENT-03, is, the endpoint here, primary endpoint is PFS by BICR, similar to ASCENT-03, and OS was the secondary endpoint. And when you look at the baseline demographics, largely what we would expect in most clinical trials, again, 30% de novo metastatic disease, and majority of these patients enrolled were recurred 12 months after disease recurrence, and we didn't have anybody who progressed within 6 months. And then in terms of chemotherapy that these patients receive, again, half and half. Half of these patients ended up getting taxane, and then the other half ended up getting a doublet or CarboGem, which is essentially the regimen that was used as part of KEYNOTE-522 regimen. The one question that we would often want to know an answer to in clinical practice, unfortunately this study doesn't answer, in terms of who received, essentially neoadjuvant KEYNOTE regimen and progressed. Would this be effective? As you can see, like the number of patients in either arm was very low, so we can't make definitive conclusions whether this is going to be effective if somebody progressed within a short time after a KEYNOTE-522 regimen. And so the SASI-Pembro combination showed improvement in PFS by BICR. It was about 11 months compared to 7.8 months with chemotherapy alone. And the response rates were largely comparable, which is not surprising because half of these patients got combination chemotherapy, 60 versus 53%. But the duration of response, as we saw it with ASCENT-03, was better. So it was 16.5 months with the SASI-Pembro versus 9.2 with chemotherapy alone. Again, similar to ASCENT-03, the OS data is immature at this time, but the initial trend seems to suggest it was favorable towards SASI and Pembro combination. And this is, looking at PFS stratified based on different subgroups. And again, one of the questions we would want to know from a pragmatic standpoint that we can't tell if it's beneficial or not because the numbers are really low. So, but in terms of efficacy, it seems equally well balanced, and for most strat factors, it favored SASI plus Pembro, regardless of what chemotherapy these patients received in the control arm. And this AEs, again, these is AEs that we would typically expect with Sacituzumab. Of course, there are IO-related toxicities that go with pembrolizumab that shouldn't significantly change whether you're on either arm. But the SASI patients ended up having a little bit of more neutropenia, fatigue, and nausea and diarrhea, and compared to patients who got chemotherapy. Thrombocytopenia and neuropathy was a little bit more in the chemotherapy arm compared to Sacituzumab arm. So this year's ASCO, they had actually kind of provided update based on TROP2 scores, and this is a question that many of us have, should we use TROP2 expression levels to stratify these patients? But you can see they had kind of split this into 4 quartiles, and then they reported saying that the PFS is maintained regardless of what the TROP2 expression level was. But I think one challenge with this analysis is it's not quite clear why that cutoff was chosen, because if you look at the biomarker data from ASCENT, all these patients would be considered high TROP2 expressors, because more than 200 would be high, but they divided them as 200 to 225, 225 to 200. So they were all in the high categories, but then broken down within that category. So they've not looked at, what if the H score is less than 200 or 200, which is how ASCENT actually did in the past. So it in some sense, this is more of a biased analysis, but it does suggest that TROP2 expression doesn't so much matter. So of course, all of this has changed our practice. Now the NCCN has updated guidelines, and of course, all 3 combinations have now been FDA approved as well. So the first line standard for patients with triple-negative breast cancers who are PD-L1 positive, based on ASCENT-04, should be Sacituzumab, pembrolizumab combination. But if these patients are PD-L1 negative, then they can either get Sacituzumab based on ASCENT-03 or datopotamab based on TROPION-Breast02. I think that's all I have. Fantastic.
Thank you so much. All right, so we're going to spend the next 5 to 10 minutes discussing Q&A for Dr. Damodaran's lecture and everything you have for the panelists. I'm going to start with this. If you look at the NCCN, when they talked about the patient with CPS less than 10, but they have a BRCA mutation, they did not include the ADCs. They still include either using a PARP inhibitor or a platinum. But for me, why shouldn't ADCs work for those patients? What do you think about that?
No, it does work.
Yeah.
But I sometimes feel like NCCN guidelines are not always updated, because they kind of add these guidelines on top of each other, but I don't think they go in and edit them, after a while. Because for a long time, if you look at NCCN, it basically said anthracycline was the preferred regimen for HER2-positive breast cancers, even though we had multiple studies showing that was not the case. So I think that could be one of the reasons, but I would absolutely use ADCs in BRCA patients. This is something of an intriguing question, and we have actually looked at our data. Sadly, it didn't show benefit, because the idea is patients with DNA, DDR pathway defect would actually respond better to topo-1-based ADCs, right? Because essentially that should predict for better response to any sort of topo-1-based ADCs, not just SASI. That should be true for Dato-DXd as well. So we actually looked at our data internally, but we were not able to show that BRCA status actually predicted better response to patients with these ADCs. So I think, but it still is active. We were hoping to say that they would do better, but they did well, but not the way we expect. So I think it's reasonable to offer ADCs.
But don't you think, given the data from Olympia, showing that the earlier on, for patients who have germline or somatic mutations in BRCA, the earlier on that you target PARP inhibition, the more likely it is to be effective, and to use that up front before going to ADCs?
Yeah, no, I think Jason was like, why is it not in the ADCs? Why? And I think that's absolutely, I think if they're CPS negative and have germline positive, I think PARP inhibitor makes a lot of sense.
You would start there if they don't have visceral crisis. That's what I would do personally.
And I'm not sure about the carboplatin part. Again, we don't have a lot of data showing that once they've progressed on PARP inhibitor, how effective platinum is. But again, that goes to the way the NCCN kind of puts these guidelines. So it's not always, the way we would want it in clinical practice.
Sure.
Fantastic. Any question from the audience?
With CNS metastases, any difference or preference?
Yeah, so with the Dato-DXd studies actually reported it, so it was definitely lesser with the Dato-DXd arm. And we know from prior SASI data, the incidence of cranial mets were lower as well. I don't remember seeing specifically for these studies, but we would expect both these agents to have intracranial activity, absolutely.
Fantastic. Any other questions? Ajit?
How will you pick between Dato versus SASI?
I mean, I think they're both equally effective.
No politician answers. Go straight to the jugular.
No, I think I was actually involved in the phase 1 Dato-DXd study, so I don't want to sound biased, but I think ultimately Dato has some advantages because in terms of using, it's Q3 administration, but the disadvantage is you have to get an ophthalmology examination and, the risk of stomatitis and things like that. The negative with SASI is the neutropenia risk, right? So that's the issue. But I think most of us are actually using prophylactic GCSF now. So I think that is not as big an issue as it is at this point. So I think both these agents are equally effective, but if you are, if it takes 2 months to get an ophthalmology exam, then I don't think Dato-DXd is the option that you should go after. You should go at SASI. So I think either option is good. The difficult question is, can you use them back to back? That is the difficult question.
Yeah.
Honestly, picking, which one is, because I don't think you'll be wrong with picking with either of them.
But Senthil, wasn't it the first study that looked at Dato? There was some patient who received prior SG and they saw some activity in those?
Correct. So in our phase 1, we did allow patients who had progressed on other TOP1-based ADCs to get Dato-DXd, right? And a few patients got SASI, and then a few got patritumab, the HER3 DXd. And that effect was only seen in triple-negative patients. So we didn't necessarily see that in HR-positive patients. But it didn't necessarily translate when the phase 3 studies were ongoing. I think part of the challenge is when the initial studies were done, we didn't have TDXd, right? So now some of these patients would have actually received TDXd, which essentially has the same payload as Dato-DXd with better DAR. So you don't know how effective Dato-DXd is going to be post-progression on TDXd. So it's a little bit of a more complex space now compared to when the phase 1 studies were done. But what the data seems to suggest is that it didn't quite matter what sequencing you do, but it's the first ADC that seems like the most active.
To add on to that, full confession, I have given Dato before eye exams. I mean, the data shows that the ocular side effects are very rare, and also the median time is after cycle 4 or 5. So generally, I don't hold the treatment for that unless the patient is asymptomatic, they're not wearing contacts, and then have the time to see an optometrist. And to be honest, no patient has the extra money to do that exam every 3 cycles. So it is also useful to keep it as a useful resource to call that person if there's an issue. But I have not had very good luck with patients doing it every 3 cycles like the label says. But again, at the end of the day, it is what is better quality of life for the patient. And is it going to the hospital, going to the optometrist, then making dinner at home? So it's just like finding that balance between a better drug and the toxicity monitoring.
Yeah,
I think that's super important.
It is very
because the
important.
life expectancy, let's remind ourselves, the life expectancy of this PD-L1 negative, triple negative population is 18 to 24 months. So the optometry exams are not really probably clinically important for the majority of our patients. Dato-DXd does require a commitment from our patients in terms of doing the eye drops 4 times a day, doing the steroid mouthwash 4 times a day. That is a huge commitment. But I got a page on Sunday, this past Sunday, about a patient who showed up for Dato who hadn't had an optometry or eye exam, and was I okay to treat them? And I'm like, in the scheme of things, like access to the drug is more important than the rare eye complication.
Yeah.
So I think that was a super important point.
Yeah.
And also something I didn't realize until recently, the optometrist can do the slit lamp exam.
Yes.
And so you do not have to wait for the
doesn't have to be an
ophthalmologist.
Yes.
Optometry
For
will
sure.
do it.
Yes. All right. Any last question?
These are also not covered by insurance, so it also depends on the financial state of the patient. So really practical discussions.
That's very important.
100%.
Any last questions? All right. Well, we're going to thank you so much for joining us today. Yeah, good. This has been